Extract 1. Questions 1 to 12. You hear a sleep specialist talking to a new patient called Georgia Douglas. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good afternoon, Mrs. Douglas. Your GP has sent you along to see me today because of some problems you're having sleeping. Is that right?
That's right. He says I've got RLS, restless leg syndrome.
I see. Well, I've got some notes here from your GP, but can you tell me in your own words how long ago this started and what's happened since then?
It all began about 18 months ago. I got this strange sensation in my legs. It was like a burning feeling, not on the skin, but inside the legs, in the muscles, and it was really uncomfortable. Then after a few weeks, it was as if there were insects moving about inside my legs. Oh, it was horrible.
Yeah.
I was fine during the day, but it started up every night as soon as I went to bed. And then it was hard to get to sleep, what with this funny feeling in my legs.
Did anything help to relieve the feelings you had?
What made it better, at least for a few minutes until it started again, was moving my legs. But it got to the point where I just had to move my legs. It was uncontrollable. That's the only way I can describe it. Eventually I'd get to sleep, but not until 2 or 3 in the morning. And my husband said that even then I was moving my legs at very regular intervals. And that kept him awake, of course. He'd lie there waiting for the next time I moved. It got us both down, and I was more and more tired. And colleagues noticed that I was sleepy at my desk. I'm an accountant. One day I even nodded off in a meeting. Someone had to nudge me to wake me up. It was very embarrassing. So eventually I just had to go to the GP, who said it was RSL.
Right. And did your GP give you any advice on what to do?
Well, he said to try to keep cool at night and use light cotton sheets rather than heavy blankets or a duvet. I'm not sure that has made much difference, though, because I certainly can't sleep if I get cold. The other thing he mentioned was doing some massage. I mean, I do it myself, and it does help to reduce the feelings. I do that before I go to bed each evening. But I can't do it whilst I'm asleep. Oh, and I've been relying more and more on black coffee and energy drinks during the day to help me stay awake. And he said to cut back on anything containing caffeine if I wanted to get a good night's rest. But then he also did a blood test for iron deficiency, because he was talking about putting me on tablets for that. But the blood test was fine, so that's not the cause of all this.
I see. And how is your health generally?
Fine. I don't smoke, and I'm not overweight or anything. At some times of year I use antihistamines, because I get bad hay fever. It's the pollen, My GP asked me if anyone in the family had ever had the same problems, but I don't remember anything like that at all. Although I mentioned that my father had type 2 diabetes, and he did say that there's sometimes a link there, but he checked and I'm not diabetic.
So what are you hoping that I can do for you?
Well, that you'll be able to suggest something to help, because I'm just feeling so tired all the time, and my husband's fed up with it all. I mean, perhaps I need to take sleeping tablets. Also, I saw online that there's a place called a sleep clinic you can go to just overnight, and they look at your sleep patterns to see what's going on. When I mentioned that to my GP, that's when he suggested I come to see you.
13 to 24. You hear a neurologist talking to a new patient called Sylvia Gunn. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Gunn. You've been referred to me because of some pain in your face. Now, I've got some notes from your GP, but perhaps you can tell me in your own words about the pain, when it started, and what's happened since?
Well, it began about 3 years back. Out of the blue, I got this terrible shooting pain in a back tooth. I've never felt anything like it before in my life. It was a tooth I'd had a nasty abscess on a few years before, and I assumed that it had got infected again. Anyway, I went off to the dentist as soon as I could get an appointment. So he did some x-rays, but he couldn't find anything wrong, which was very strange.
Was the pain continuous, and did anything in particular trigger it?
It came and went, and it lasted just a minute or so each time, but it really got bad when I brushed my teeth. I always use an electric toothbrush. They're so much better than the usual sort, but I didn't like that one little bit. I even tried to persuade the dentist to whip the tooth out there and then, because I was so sure that that was the problem. But he told me he was pretty sure there was nothing wrong with my teeth at all, and I ought to see my GP.
And your GP has diagnosed trigeminal neuralgia.
Well, first of all, the GP told me to try painkillers. That was to exclude things like a migraine, I think, but the pills, they didn't have any effect at all. So then he sent me off for a CT scan, because he said it might be a very bad case of sinusitis. I'd had that before when I was a teenager. Or he said even nerve damage, but that was all negative too. So then after all that, the GP eventually put me on an anti-epilepsy drug, which seemed to help.
I see. So how is it now?
Well, the pain sometimes goes away for weeks at a time, but then it can come back a dozen times a day. Fortunately, I get a tingling feeling in my jaw when it's going to start, which I can recognise as a sign, so at least I get a bit of warning before the pain comes on properly, and I can try to find somewhere quiet to sit down.
But the pain has now begun to spread.
Yes. It started to happen in my eye, too, on the same side as the tooth. I was doing okay until the firm where I work moved to a new office. It's a lovely new building, and everything was fine at first until about 3 months ago, when the weather started to improve and they turned up the air conditioning, because lots of people were complaining about being too hot. That's when I started getting pains in the eye, and I'm pretty sure it's connected. But the system's the same all over the building, and it's not as if I'm sitting in a draft, so there's not much I can do about it. I've tried wearing glasses all the time, and that seemed to help a bit, at least at the beginning.
And these pains in the eye, tell me how long they last and how often you get them.
It's getting worse and worse. Over the last fortnight, it's been every day, and sometimes every hour, and it's really excruciating. It's getting me down, and I've started losing weight too, what with the worry and the pain, and I've had to give up my yoga class, which I loved, because you never know when the pain's going to come on. And, well, that's making me feel very isolated. I really hope you can do something more for me, Doctor.
That is the end of Part A. Now look at Part B.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a consultant talking to a woman whose father has just been admitted to hospital. Now read the question.
So we've talked about the various things that might have caused your father to collapse. A lot of times we investigate multiple symptoms so as to rule out any life-threatening conditions.
So it could take some time to get to the bottom of the problem?
Possibly. In the meantime, he's quite stable now, and we're encouraged by the progress that he's making.
Well, I'm glad to hear that. But at least he's not in any great discomfort, is he?
According to the assessment at the bedside by his nurse, his pain is well controlled, and we'll try to keep his sedation at an adequate level until we're ready to begin treatment.
Question 26. You hear a trainee nurse receiving feedback from her tutor about the ward round she's just completed. Now read the question.
How do you feel your ward round went with that patient?
Oh, I really should have told him what I was about to do, rather than just rolling up his sleeve to take his blood pressure.
Yeah, it would have been preferable, but at least you realise.
Thanks.
I think you did your observations really well, though. You checked the patient's details are correct, you put the date in, you timed it correctly, you observed that all your parameters are within normal range, and you did the respiratory rate while you were doing your manual pulse.
Yes, the pulse was quite strong and regular.
And you could have passed that on to reassure the patient too.
Oh.
But you look back at the previous observations, put your signature at the bottom. That's all good.
Thanks, okay.
Question 27. You hear a hospital nurse briefing a colleague about a patient with chronic obstructive pulmonary disease, or COPD. Now read the question.
So who's next?
The patient in bed 12, she had a fall at home about a month ago, but she's otherwise independent with her day-to-day activities. Her falls risk is high given her recent history. She's been assessed by the physio, and she's on a rollator frame to ambulate. Her skin integrity is intact, and she's responded well to all treatment.
Good.
She's on a normal diet. The observations were last done at 6 a.m., and they were stable. Her medications are IV tazocin due at 2 p.m. and prednisone next due at 8 a.m. tomorrow.
Okay.
You need to check with the doctors today whether she'll continue with the IV antibiotics and whether the cannula can be removed. At this stage, they're aiming for discharge in a couple of days' time, pending discharge from the physio and also ceasing IV antibiotics.
Okay, thanks. Question 28. You hear a discussion between a doctor and a nurse about autoimmune liver disease. Now read the question. Hello, doctor. What are the autoimmune liver disease?
Well, autoimmune hepatitis, primary biliary cirrhosis, and primary sclerosing cholangitis are the three most common forms of autoimmune liver disease. Autoimmune hepatitis is characterized by high levels of serum alanine aminotransferase and aspartate aminotransferase, whereas primary biliary cirrhosis and primary sclerosing cholangitis are associated with predominant elevations of alkaline phosphatase since they are cholestatic disorders. Primary biliary cirrhosis and autoimmune hepatitis are associated with autoantibodies in the serum, such as anti-nuclear antibody, smooth muscle antibody, and anti-mitochondrial antibody. Primary sclerosing cholangitis usually affects the extrahepatic biliary system. Thus, if it is present, abnormalities can be seen on imaging.
Question 29. You hear a discussion about brain chemicals involved in mood regulation. Now read the question. Hello, doctor. What are the brain chemicals involved in mood regulation?
Well, basically there are three molecules, chemically known as monoamines, that are involved in mood regulation. Serotonin has been coined the brain's feel-good chemical. Norepinephrine is another neurotransmitter connected with depression and how alert the feelings are. A low level of norepinephrine is considered to be associated with the brain fog that many people with depression experience, whereas low levels of dopamine in a part of the brain called the substantia nigra associated with Parkinson's disease. But there is much more to dopamine. In the frontal lobes of the brain, it is associated with complex thinking and problem solving. In fact, it is considered that the stimulatory effects of chemicals such as nicotine and cocaine are related to their effects on the dopamine-mediated reward centers in the brain.
Question 30. You hear a discussion about different types of gastric juices. Now read the question.
Hello, doctor. What are the different types of gastric juices?
Well, the food we swallow mixes with gastric juices secreted by special glands in the lining of the stomach. They include the cardiac glands at the top part of the stomach, the oxyntic glands in the main part of the stomach, and the pleuric glands in the antrum or lowest part of the stomach. Therefore, each of the glands contains cells that produce specific components that are called the gastric juices. Neck cells produce bicarbonate and mucus. Parietal cells generate hydrochloric acid. Chief cells produce pepsinogen, and enteroendocrine cells generate various hormones. Hydrochloric acid is a strong acid secreted by the parietal cells, and it lowers the pH level of the stomach to around 2. Hydrochloric acid converts pepsinogen into pepsin and breaks various nutrients apart from the food we eat. It also destroys bacteria that comes along with the food. Gastric lipase is another digestive enzyme made by the chief cells. It helps break down short and medium-chain fats. Amylase is also found in gastric juices, but it isn't made by the stomach. This enzyme comes from saliva and travels along the bolus into the stomach. Amylase breaks down carbohydrates, but doesn't have much time to work on the stomach because the acidity stops it. Intrinsic factor is secreted by the parietal cells and is necessary to absorb vitamin B12. This is essential for healthy nervous system function and blood cell production. Finally, the gastric juices contain water and mucus. The mucus is secreted by the neck cells and helps coat and protect the stomach lining from the acid environment.
This is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1, questions 31 to 36. You hear the lecture given by a physician on colectomy surgery. You have 90 seconds to read questions 31 to 36.
Hello, Doctor. Please explain to me different types of colectomy surgery.
Well, the surgery to part of or all the colon or the large intestine is called a colectomy, and there are many types of colectomy surgeries. The type of surgery and how much the colon is removed based on the disease and the extent of damage to the large intestine. In the proctocolectomy, the colon is removed along with the rectum. The term procto refers to rectum. With both the colon and the rectum removed, the body will need a new way to dispose of stool. For most people with inflammatory bowel disease, either ulcerative colitis or Crohn's disease, a proctocolectomy also means the creation of an ileostomy. When part of the small intestine is brought through the abdomen to create a stoma, it is called an ileostomy. Therefore, the stool can be passed through the stoma and is received in an ostomy device worn on the outside of the body. The ileostomy can be temporary or permanent. Jpap surgery is an ileopouch-anal anastomosis, which is done along with proctocolectomy or after proctocolectomy. In this surgery, the last part of the small intestine, called the terminal ileum, is sewn together in the shape of a J and can then hold stool for a period of time, serving like a rectum. Ileoanal anastomosis is done to restore the ability to move stool through the anus. In this surgery, after the rectum and colon are removed, the small intestine is connected directly to the anus. In the total colectomy surgery, entire colon will be removed. Unlike proctocolectomy, the rectum is not removed in this surgery. A total colectomy with partial or complete rectum left in place may be done in certain cases of either Crohn's disease or ulcerative colitis. In a partial colectomy, part of the colon is removed, and it may also sometimes be called a subtotal colectomy. A partial colectomy may be done for certain patients with Crohn's disease, while it is also done to treat colon cancer or diverticulitis. This surgery is never done for the patients with ulcerative colitis, since the disease will often recur in the healthy section of the colon that is left. In hemicolectomy surgery, either the left or the right part of the colon is removed. In a right hemicolectomy, the cecum, ascending colon, and a portion of the transverse colon are removed, along with the appendix is attached to the ascending colon. Whereas in a left hemicolectomy, the descending colon and part of the transverse colon are removed. In this surgery, typically the healthy sections of the colon are connected together. Therefore, an ostomy is not required.
Extract 2, questions 37 to 42. You hear an interview with Dr. Janae Brown discussing a neurological condition. You now have 90 seconds to read questions 37 to 42.
Welcome to the Health Matters podcast. Joining me today is Dr. Janae Brown, all the way from the East Coast. Dr. Brown, thank you for flying in.
Thank you, Ricky. It's a pleasure to be here.
So I know that you deal with many neurological conditions, but I understand that today you'll be talking to our listeners about one in particular. Tell us, Dr. Brown, what is multiple sclerosis, and how many people have got it?
Multiple sclerosis is a neurovascular disease that affects the brain and the spinal cord. Usually the nerve fibers of the central nervous system are protected by myelin. Myelin helps the nerve fibers to transfer messages faster between the brain and the rest of the body. When multiple sclerosis sets in, the immune system identifies myelin as foreign and in turn destroys it. The damage then interrupts the message pathway by suppressing the myelin completely or stripping some parts of it, leading to the formation of scars. The disease is lifelong once someone is diagnosed, though with proper specialized management, a person can survive for long. According to the United Kingdom's National Health Survey, there are more than 100,000 people diagnosed with multiple sclerosis annually.
Are there many risk factors of multiple sclerosis? And could you give us examples of the effect the condition can have on its sufferers?
Yes, there are several risk factors that are associated with multiple cases of sclerosis, such as gender, family history, geographical location, lifestyle, and vitamin D deficiency, among others. When the diseases are in one person in the family, the risk of passing the genes to the children is very high. Also, women are at a higher risk of developing MS. The risk is made higher due to the hormonal differences. Furthermore, in areas that are further from the equator, the risk of developing the disease is high in the regions that are more than 40 degrees. The condition affects people of all ages, but most people are diagnosed between the ages of 20 to 50 years old. In terms of lifestyle, smoking is also associated with the formation of multiple sclerosis, although admittedly more research is required in order to clarify the reason for this.
What are the main effects of MS?
MS affects the whole body depending on the nerve that is affected. Different nerves innervate different parts of the body. The main symptom is weakness or numbness in one or more limbs. This usually occurs on either side of the body or trunk, one at a time. When the optic nerve is affected, the patient may have prolonged problems with double vision accompanied by extreme pain. The person might also lose sight in one eye with time. The patient may experience Lhermitte's sign, that is a feeling of electric shock sensation around the neck during movement, as well as when one bends the neck forward. The patient may also present with a problem with their gait or body coordination. Fatigue and dizziness may also be a problem. When the nerves innervating the speech center are affected, the patient may develop slurred speech. The gastrointestinal function can be changed, as well as bladder function, especially in continence problems.
Would you tell us a little bit about the diagnosis procedure?
Early diagnosis is preferable, Ricky, before the treatment of multiple sclerosis. Diagnosis methods range from laboratory tests and imaging tests such as magnetic resonance. For laboratory tests, the spinal fluid is tapped and taken for culturing and sensitivity. The liquid is drawn after lumbar puncture and carried out using sterilized equipment. This helps in knowing whether the cause is due to infection or not. Imaging helps in understanding the extent to which the disease has affected the nerves, especially within the brain.
It's all so fascinating. So, Dr. Brown, would you talk to us about the treatment options, what they are and their main aims too?
Yes. MS is chronic, and treatment options mainly involve management of the symptoms. The goals of treatment revolve around ensuring that patients recover from attacks as well as recurrent situations, as well as slowing the speed at which the disease progresses. For the treatment of seizures, the patient can be given corticosteroids and plasmapheresis can be done too. Corticosteroids reduce the inflammation of nerves. Examples include oral prednisolone and methylprednisolone, given through the vein. The process is mostly used in severe cases of the disease, especially when the symptoms are not improving through use of steroids. Beta interferons can also be used primarily in the relapsing-remitting stages of the disease when it is still aggressive. Furthermore, other medication like this can be used in various stages of the disease.
That is the end of Part C. You now have 2 minutes to check your work.